A very good evening and a very warm welcome to everyone. This is Batul from IGCP, the moderator for today's session, and I would like to welcome everyone wholeheartedly at our platform for the better exchange of knowledge that is going to be shared by our renowned stalwart who is here with us today. And the topic for today's discussion is coronary angiogram best imaging and interpreting tips. And to talk about this topic, we have a very renowned cardiologist with us who is none other than Dr. Ramamurthy Bengi, sir. So, with this, we would be talking about the topic. And before we move on to the topic, I would like to briefly describe you about what the topic is. So, in this webinar, our expert in cardiovascular imaging will share invaluable tips, techniques, and interpretation strategies to optimize the quality and accuracy of coronary angiograms. Whether you are a seasoned interventional cardiologist or an aspiring fellow or a healthcare provider involved in a cardiovascular care, this webinar is going to offer an indispensable guidance to elevate your expertise in coronoangiography. So now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him for his precious talk to begin. So over to you.
Thank you very much. Thank you. I think I'm audible at that side and visible also. Thank you, my friends there at a short time. This is actually going to be an extempore talk. I don't have any slides. I'm not going to show any angio pictures. You may say it is going to be a little dull, but don't bother about it. I will try to tell you not about the technique of doing a coronary angiogram, but how to interpret the coronary angiogram. You all know that coronary angiogram has emerged as a very important investigation for the management of ischemic heart disease. Ischemic heart disease, in fact, it turns out as majority of the time it is because the coronary obstructive disease, also known as coronary artery disease, or some people call it as coronary atherosclerotic disease. And we have to make out whether there's any obstructions visible by giving a dye. Well, that is the reason why we call it as a contrast coronary angiogram. And apart from that, you have learned last few years, we have another modality of looking at the coronary anatomy, that is by the so-called CT coronary angiogram. Basically, this sort of investigations are evolving in order to see that they become more user-friendly and they are more, not painful to the patient. That is how the aim is. So when we are investigating coronary artery disease, we move from one side to the other side. Apart from the history examination, we usually ask for an ECG, an echocardiogram, and a treadmill test. Echocardiogram gives you an anatomical knowledge about how the ventricle is doing. We can recognize some regional wall motion abnormalities. Indirectly, we can interpret the arterial territory in that arterial a segment in that territory is probably blocked or not able to supply the blood flow at rest time. This gives us an indirect evidence. On the other hand, we try to do what is called the treadmill test. Treadmill test or a treadmill ECG or exercise ECG, various names which we call them as, is an very cost-effective test. I'm not saying no, but this is not only cost-effective, it is easily available to everybody in any general hospital and practicing physicians. Unfortunately, the treadmill test interpretation is very much scientific. In fact, if you really look at a treadmill, we try to get the knowledge in terms of the ECG abnormalities mimicking a myocardial ischemia. Second thing is we try to look at the heart rate response and the blood pressure response, the so-called hemodynamic response. Is there any recurrence of the symptoms? And this is how we try to take it into consideration. But as the science has evolved, we have understood there is a pre-test probability and post-test probability, so-called sensitivity, specificity, predictive value. So many statistical terms have come up, and an ordinary physician's mind is really boggled and muddy in interpreting this ECG. It does give an approximate idea that there is a myocardial ischemia when the patient undergoes some amount of stress, like walking or what is called as a controlled walking that we do on a treadmill by various defined protocols. The most popular protocol is the so-called Bruce protocol. As I said, this even in the Western countries, in the statistics, but even in our country, the sensitivity of picking up the disease is hardly about 60%. You come down to roughly an average of 50%, 50 to 60%. In a way, in hardly about two patients, you can one out of the two people, you can say maybe the test is going to be helpful for you. Another person it may not be able to help for you because many of us are particularly busy practitioners may not have enough time to really interpret in the background of the probability of the disease and pre-test likelihood and post-test likelihood. And thus, treadmill test is basically not so very uh, useful in recognizing an ischemic heart disease. But at the same time, mark my word, this is an easily available test, cost effective. Anywhere it costs somewhere between 1,500 or 2,500. Whereas coronary angiogram is much more costly, it is invasive, it has got its own risk. Possible risk is there, including a finite amount of a death while doing a coronary angiogram. We usually don't stress upon that, but this is what it is. So when we use an dye, what we call as the contrast, is an iodine substance, and because of the iodine molecule, it makes the coronary arteries, when it is passing through that solution, makes them opaque. And since the heart is a continuously moving structure, having various phases of systole and diastole, we do take these pictures in a rapid sequence in the form of a cine. We call it as a cine coronary angiogram. And this being, that just an anatomical knowledge that I'm trying to give it to you, that heart is not exactly sitting in the center of the heart, nor it is exactly sitting in an anterior posterior um, right left orientation. It is inclined towards the left side, outward and downward into the left chest. And thus, what we call it is the long axis of the heart never corresponds to the long axis of the chest wall. And thus, we may have to introduce some angulations to take the coronary anatomy. So, you know that coronary arteries are coursing over the surface of the heart in a more particular angle, and we are supposed to take that in that angle, and that is why we always give what is called as a cranial or a caudal angulations. So the present picturization of the coronary artery cine angiograms is basically in various cranial angulations. So you have a left side, left anterior oblique views, right side, right anterior oblique views, and you have a cranial angulation, cranial angulated views, caudal angulation, caudal angulated views, and sometimes we have on the RFO side, RFO caudal and RFO cranial. There are other views also we do take, and fortunately, unfortunately, these views are not being quite frequently practiced. Earlier, many of you remember we used to put what is called the left lateral view to look at the mid segment of the anterior artery. But nowadays we don't do that much. Only in a case of an already undergone bypass surgery, you want to see the arterial the so-called the lima that has been joined to the a lady. You can visualize it properly. And similarly, there are many people who do take just a simple plain cranial, epicranial or cranial, whatever you would like to call, and then caudal views, with the idea of stretching the left anterior artery in a much better way and this is often being practiced. But in coronary angiogram, the coronary angiography study has become more and more an area for decision making for angioplasty. It is so. An angioplaster often has to keep it in mind. Angiogram is not that safe, as apart from having some inherent risk. There is a possibility of a dye reaction. There is a possibility of a radiation. The radiation effect can be present. The more nearer the field of radiation you are there or the patient is there. And this radiation is maximum if you are doing it in simple PA waves and sometimes very near to the caudal waves also. And that is why you should be very selective in using some of these waves. So this apart, let me go ahead and tell you. The coronary angiogram, when we are asking ourselves, we have to ask fundamentally three questions. Whether this coronary angiogram is going to help the patient. If it is not helping the patient, is it helping me in making a decision for the further on treatment, either by angioplasty or bypass surgery or medical treatment? And then it should also be able to give you some amount of prognosis. Now, in coronary artery disease, there are four issues. One should keep them in their mind, very clear cut. These four issues are the determinants of the prognosis. One is the severity of the coronary obstruction and extent of the coronary artery disease, as we see in a coronary angiogram. Now, we understand by this particular statement, the coronary angiogram is a very important investigation to prognosticate about the patient's future. And second one is the presence of a myocardial ischemia. The myocardial ischemia is assessed by the patient's complaint of angina or angina equivalent, or by documenting in a laboratory in the form of a treadmill or a stress thallium test and the like. And the third thing is the presence of a LV dysfunction. LV dysfunction has emerged as a very important determinant of the risk of the future death. The more severe the LV dysfunction, more severe the problem. Similarly, we all know that the more severe the LV dysfunction is, the the outcome of the surgery is not that good. The risk of surgery also outweighs. There are very few surgeons all over the world who are really bold enough to take up a case of a say 18 to 20% ejection fraction, even if the targets are quite good. So this is an important point to make a decision also. Fourth thing is ventricular irritability. This is the generic term which I am talking. Ventricular irritability manifests in the patient in the form of frequent premature ventricular contractions or an recurrent episodes of ventricular tachycardia. This is also a very important prognostic factor. Thus, to recapitulate, the four important factors in prognostication are the extent and severity of the coronary artery disease. Second is LV dysfunction. Third is ventricular irritability and demonstrable ischemia, either spontaneously by symptoms or by the tests. These are the four important things. That is why a coronary angiogram had become a very important investigation. Now, there are many times coronary angiogram we do because of many, if you try to look and to categorize the patients into the so-called high risk category, low risk category, or intermediate risk category, or high probability, intermediate probability, and low probability of a coronary artery disease. The best yield appears to be in the intermediate category. In the low risk category, you have already made a diagnosis by the ECG, by there are no symptoms, atypical symptoms underlying. You know that they are under low risk. There is no need of doing a coronary angiogram. High one, you have to do the coronary angiogram in order to make a therapeutic decision. Whereas the intermediate, sometimes for a diagnostic purpose, you may have to do the coronary angiogram. And the positive yield of the diagnosis often varies depending upon the clinical context. Are we dealing with the chronic ischemic heart disease? Is it an acute coronary syndrome, an unstable angina, and the like? Now, if you take an population like an unstable angina, if you do 100 cases of unstable angina, take them up on the table and do the angiogram, you will be able to see about 10% of them having left main disease. Another, say, 15% will not be having any coronary disease. That means about 25% of the patients you are able to make a diagnosis either towards the surgery or to the medical treatment. And the remaining 25% to 30% will have triple vessel disease. Another 25 to 30% will have a double vessel disease, and maybe another 15 to 20% will have a single vessel disease. So it is if you really look at a diagnostic wise, the yield is about 25 to 30%. You can straight away say that there is either the disease is there or very severe disease is there. That is why we may have to do a coronary angiogram to do really select out the cases for either medical treatment or surgical treatment. Apart from that, we have recognized many patients we do come across, and they say they have a typical angina. But when we do the treadmill test is positive. But looking at that, we do take the patients on angiogram. When we do the angiogram, we have got some other entities that are seen, which we have never expected, nor our stethoscope could pick it up. Now, these include the coronary spasm, sometimes coronary artery anomalies. The more important in practice, I have my own observation is slow recognition. If you do a slow cine re-evaluation, this is very important. When we do a coronary angiogram, on the table, fluoroscopic visualization and cine visualization, we should not comment to the patient. We have a tendency to comment, okay, your coronaries are normal. It's okay, fine. And we may be discharged tomorrow. Or you may come with a medical treatment, something like that. But if you have with a cool mind, you change your dress, come down, sit in front of the machine and analyze in a slow motion, you often find an systolic sort of a compression either in a LAD or one of the OM branches because this so-called phenomenon of myocardial bridging. So this we would have missed in a hurry to talk about it. So myocardial bridging, normal coronaries, coronary spasms, coronary anatomy anomalies, particularly arising from some other segment. These are some of the entities which we can pick up by looking at the coronary angiogram. When a patient comes with a typical angina and we make out the coronary angiogram is normal, it doesn't end there. It is a very big chapter by itself. Ischemic heart disease or chest pain or or angina pectoris with the normal coronary disease. But it is probably we are narrowing it down, our interpretation uh, in something else. So I usually talk to my students in that the coronary artery disease is first and foremost is the so-called conduit vessel problem. That is, main coronary artery blocks are there or not. Once you see that there is no conduit problem, it may be in a mismatch in the supply and the demand. Patient may be having a significant hypertensive heart disease, left ventricular hypertrophy, that itself making him an angina because there is the demand is more, but the normal coronaries are not able to supply. The third thing is there is so-called small vessel diseases. This is often seen in entities, collagen vascular disease entities, like you know, um, Marfan syndrome. Maybe the other entities like rheumatoid arthritis, and these cannot be made out in a simple conventional angiogram. The vessels that are often affected here are between 0 0.1 to 0.3 millimeter size. These will not be picked up in a simple contrast angiogram. Then we have small vessel disease. More than the small vessel disease, the present attention has been more on what is called as abnormal coronary reserve. Here, the vessels appear to be all right, but overall, their dilatory capacity of the coronaries being controlled by the smallest of the coronary arteries is abnormal. So you have in a segment, it's a cascade starting from a gross atherosclerotic abnormalities to the small vessel disease to the abnormalities of the supply demand ratio to the level of coronary reserve. So, just seeing a normal coronary does not exclude that there is an everything is fine. Coronary artery disease may be still present. We have to exclude by comparing them with other modalities. In this, there are some so-called myocardial perfusion tests, particularly when the abnormalities is existing or a TMT is not matching, the area of stenosis is not matching. We may have to ask for that. Then the decision making is most important as far as the coronaries are concerned. Many a times there is a hurry burry in making uh, an image, and here sometimes we don't fill the coronary properly with the dye. Sometimes we don't watch the distal flow. Sometimes we don't see that there is an little bit of an what we call as a dye staining or some amount of a sluggish flow in the artery. And sometimes we don't even see that once the coronary flow happens down, the collaterals are sufficient or not sufficient. And these aspects should be very, very thoroughly evaluated. We have observed in patients having unstable angina quite frequently. When we put a dye, the dye doesn't flow off easily. The TIMI uh, flow, what we call as a two flow, three flow, or a zero flow. Usually we find a timid two flow. And here the flow is little sluggish. This is called as the slow flow phenomena. Slow flow phenomena or no flow phenomena, whatever we call it as in a post PCI cases, is not seen only in PCI patient. It is even seen with the normal patients without having obstructive lesions. So we should understand this may be a manifestation of maybe endothelial dysfunction. There is a sluggish flow, and often these patients with intensified anticoagulants and antiplatelet drugs over a period of time do improve. And anyway, there is no lesion, visible lesion. These are not the candidates for PCI. Second thing is we do often see in unstable angina patients. Luckily for the patient, there is of course when we do an um, you know angioscope study or imaging studies, we may see an cracked atherosclerotic lesion or overall it is a non-occlusive lesion. Here there is a little bit of a dye staining, and sometimes you feel as if the dye is moving from one side front to the back, front to the left, something like a ping pong ball like. And this is often seen in unstable angina. This is a quite an important phenomena. We can recognize, we can assure, we can put intensive anticoagulant therapy. And last but not the least, we do sometimes see that the patients having some occasionally spontaneous dissections, but in my view, it is then inadvertent use of the catheter, not being concentrating, the catheter being kept little hooked upwards and injecting little forcefully that can create a dissection. But spontaneous dissection, particularly female patients, is a very known phenomena, and that has been responsible for acute MIs, arrhythmias, sudden deaths, and it can be recognized only by doing a coronary angiogram. The most important point from our angle is now we are going into the field of so-called intervention. So I should do an angiogram to make a decision whether this particular patient needs an intervention or not. So, in this regard, we should image the lesion very well. So, I would say for the youngsters, you try to look at, I don't know, earlier days we used to say, you should analyze an ECG in terms of the initial vector, mid vector, late vector, like that. You should analyze the coronary artery, a proximal segment, mid segment, and a distal segment. And then accordingly, you should lengthen that particular segment to get the best view of the lesion. Because if you don't do that, many of the eccentric lesions will be missed, and interpretation of the percentage of the stenosis is often variable. There is a significant amount of inter-individual variability and intra-individual variability, and we should be very careful when we are commenting about the percentage stenosis. So, in order to see the best one, we have to lengthen the artery, and the second thing is we have to get what is called as an orthogonal wave. Don't comment in one particular wave; you have to comment in two waves, the so-called orthogonal waves, and try to give the real percentage stenosis. Here, the percentage stenosis are concerned, there is two confusing terms are there. One, sometimes the for research purposes, percentage area stenosis, they do say. Now, many a time we do talk about the percentage the diameter stenosis. We take the proximal segment or the distal segment and average the two and take a measurement, and then out of that, visually, most of the time we do have machines called QCA machines. We don't usually do so frequently. We do measure and take a percentage. And I have seen a lot of the time in the literature, people talking about 70% stenosis, 30% stenosis, 30 to 40% stenosis, minor plaquing, minor irregularity. I think all these ambiguous terms should be avoided as much as possible. For your visual, if you are thinking that it is a tube, you can either think that there is a complete occlusion or there is a trickle of flow that is happening, say like 95% occlusion. 95% occlusion is like more like 100% occlusion. Flow is very sluggish. And you can make it 25% stenosis, 50% stenosis, 75% stenosis. And this is by visual. But if you're using calipers or using electronic methods, you can pinpoint and say 72.5 millimeters stenosis. That is a different entity. But practice is practice, whatever we do, we have to really just be more practical when we are looking in the cath lab. It should be either of the diameter, but it cannot be 28 millimeter, 28% stenosis. This is impossible. So this sort of ambiguous word should be avoided. And of course, lesion has to be described in terms of the complexity, the length of the stenosis, particularly those who are doing a lot of angioplasties. We know that complex lesions have got more complication issues, and that is why we should know. And the as I said, more severe the stenosis, then the flow is the possibility of limitation is there. Majority of the time at rest, 50 to 75% diameter stenosis. Beyond 75% stenosis, the symptoms become even at rest. Between 50 to 70%, the symptoms may come on an extreme exertion, extreme walking, that going up the hill. As many a times for interventional purpose, 50 to 60%, something like that. There is a vagueness whether it should be done or not because of the so-called physiological assessments have come. Okay, but when you are mentioning an number of vessels that are a disease, usually we take one of the artery, important artery, is about 75% stenosis. Another two arteries, even 50% stenosis are there, we can consider it as a three vessel disease. If it is only 40% or 25%, it cannot be equated to as triple vessel disease or a double vessel disease. There is some individual variation from one physician to other physician, but this is the methodology of communicating to the people. And some people even go to the extent of saying, no, it should be there in the proximal and mid segment only. If it's a distal segment, small one, don't mention it. But in giving a report or interpreting, you are supposed to mention distal also. Distal segment stenosis become very important from the surgeon point of view. Now, when a patient has got a triple vessel disease and you say that patient needs to be undergoing a bypass surgery, a graft has to be poured, the artery beyond the stenosis should be quite a big size and it should have some minimum diameter and a minimum flow. And equally, it should be a graftable enough size. So that is why we call it as a distal segments flow is good, distal segment size is good or not, distal segment graftable or not. Sometimes we do make comments which is helpful for the surgeon so that he can select out for the areas for the grafting purpose. But otherwise, the interventional cardiology, we're only interested the lesion type, and the possible distal flow that is happening. And of course, one should also have a very significant value has to be given to the collaterals. Unfortunately, collaterals are so much variable from one individual to another individual. We have seen an angiogram, and the acute MI has happened. We already see a lot of collaterals. There are some patients who have got a chronic effort angina lasting for more than 3-4 years, and they have undergone angiogram. Sometimes the collaterals are so poor. There is a significant variability depending upon one individual to other individual. Overall consensus is that the more recurrent chronic ischemia is there, as in chronic ischemic heart disease, the development of collaterals is high. We have seen collaterals more frequently when one of the arteries is totally occluded, another artery is supplying the collaterals. And this is important, we should not take it lightly. One many a times in ischemia or infarct, we expect from if a segment is in the proximal area, we expect a large area of myocardium getting infarcted. But in the angina, in the symptoms wise and by ECG wise, in the way patient has made recovery, we make out that it's a small area. So there is a little discrepancy between the extent of the coronary artery disease, and there is one more term which we call it as a Jeopardy score. We should try to calculate as much as possible. And this particular applies when there are some collateral development. We have seen many a times the patient has gotten chronic RC occlusion. This often happens in the right coronary artery territory. Suddenly, the vessel in the LAD starts becoming growing over a period of time, 70-75%. Suddenly, patient develops a total occlusion. Patient often goes into collapse. And because the collaterals that were coming from that area, they become compromised. So collaterals recognition is important and its interpretation is important from the coronary angio point of view. And as per the triple vessel disease concerned, or double vessel disease or single vessel disease when we call, major trials that came earlier, so-called CAS trial, CAS study, European study, veteran study, all of them, they molded our thinking in terms of the selection for CABG. Now, we all know that left main, even if it is more than 50%, there is an element of sudden death here. And the area that is compromised is too big, both in the LAD territory as well as in the LCX territory. So the people are often of the opinion that it should be subjected for surgery, but over a period of time now we have become bold enough even to do PCI to the left main stenosis. This is again a selection of the cases here. So in overall, left main is an indication for bypass surgery. Similarly, triple vessel disease, if the vessels are easily graftable, if the patient is symptomatic with the angina, the recommendation is for bypass surgery. If it's a two-vessel disease, one of the territories is left anterior descending artery. Again, some people prefer bypass surgery. Some people can do PCI. Single vessel disease is an area for PCI interventions. But in the elderly territory, there is a little controversy, particularly the patient is a diabetic, because they try to look at amount of recurring ischemia, the risk of possible MI in the future, and the like. But since we have been evolving over the PCI results over a period of years with the powerful antiplatelet drugs and the newly available second, third generation drug eluting stents, our results are much better than the surgical one. Of course, any patient who is told to avoid a bypass surgery and opening the chest is always happy to accept for a PCI. One is costly, one is a possibility of recurrent ischemia, and one is a possibility that there can be a need in the future for a bypass surgery. Should be all discussed with the patients and patients' relatives. And this is how a coronary angiogram helps you in recognizing some entities which you have never dreamt of, like anomalies, something like a myocardial bridging, something like a coronary reserve, indirect evidences, and myocardial coronary spasm. Other than that, you will make out structural abnormalities like atherosclerotic lesions, extent of the lesions, which often help you in decision making either for PCI or CABG or medical treatment. We do often see patients who have hostile lesions of the diagonal alone. Particularly, it happens in women. They go on complaining of severe angina. And many a times, these measures are less than about 2 to 2.5 millimeter. We know that is any vessel which is about 2.5 milliliter. If we try to do an angioplasty, the recurrence rate is high. Similarly, that size, nobody can do an bypass surgery. So in that cases, we always try to give them an optimal medical treatment. There may be some diffuse disease which we often see in diabetic patients, particularly distal diffuse disease. We do recommend only medical treatment. So the coronary angiogram helps in many ways in our decision making to opt out the particular treatment in a particular patient. And if you use this coronary angiogram study in the background of the age of the patient, his general well being, his economic status, his symptoms that are existing, and his LV function that is existing, we are doing a great service in making a decision either in terms of surgery, medicine, or PCI. We should not forget these fundamentals of medical, or what I can call is a clinical cardiology. With these few remarks, I think I will wind up this lecture. I'm sorry if I have not shown you any cine films for you, but I have tried to cover as much as possible how to make decisions on the angiogram itself. Thank you very much. Any questions or comments, I'll be able to answer.
Thank you so much, sir. Thank you for your wonderful talk that you have shared. Even though without the PPT, you have done complete justice to the talk. So thank you so much for that. We have
Thank you.
received few questions from the participants. So I would like to put across the first question, and the question is related to assessment. So how do you accurately assess the severity of coronary stenosis based on angiographic images?
That is what if I see the arterial segment in two angles and I make out the whichever for example, in an caudal wave, I make out it is about 75%. But in an cranial wave, I've seen it is hardly about less than 50%. I to try to take the whichever area, whichever the angle I've seen is the maximum stenosis, and that is how I say it's the 75% stenosis, something like that. So I usually mention with the proximal, mid segment, or less segment, whether it's a discrete, whether it's a tubular, it is a long segment, and whether it is sometimes if you are smart, some we have to answer some. The distal vessel is graftable, not graftable, and I think we are doing a great service to our cardiac surgeons also, so that he can plan and decide. Yes, these arteries are small. Some may not be good, something like that. But here, let me be very frank with you. Sometimes the distal arterial size is often, it gives away to you saying that it's a small vessel. When we do open the lesions, often the artery grows, and sometimes with the nitroglycerin also it grows. So that is why we should be very very careful. Diffuse diseases or underfilled vessels, to make a difference is very difficult thing anyway.
Thank you so much. So thank you for answering that question. We'll move to the next question and the last question for today's session before we conclude. And the question is related to the common complications encountered during coronary angiograms.
Yes, the main complications are earlier when we were practicing femoral route. Now it has become more of a radial route. This used to be little bit of a pain lingering over a period of up to 4 to 6 hours. There is a slight swelling. There is a little induration on the second day, hematoma formation, pseudoaneurysm formation, AV fistula formation, that is femoral vein and femoral arterial fistula formations, and hemorrhage, significant hemorrhage. These were some of the major complications as far as the local site is concerned. Apart from that, I have seen patients sometimes developing suddenly allergy to the dye. Earlier, we used to use an not so refined contrast agents. That is why they used to have a lot of skin allergies, sometimes going to the level of anaphylaxis also. And the worst complication of coronary angiogram is because of the arrhythmias and the hypotension. More than that, it is because of criticality of the stenosis. When you do an angiogram, you see that sometimes it is a 95% stenosis. Left main is very highly stenosed. Some of these patients, they do have hemodynamic collapse. There may be a death. So the coronary angiogram and the contrast coronary angiogram is not such a safe procedure. There are some risks, but the benefits of giving the knowledge for yourself and to the patient is immense. That is why one should not hesitate to do that. And I've seen patients earlier days when we do the coronary angiogram, suddenly their parotids used to swell up. Okay, that is because the iodine effect. Okay, and these are some of the things. And now we have also seen you have done an angiogram and shifted the patient to the ward. Suddenly, the nurse comes and says that there is a fall in the blood pressure. It does happen because the dye effect, the vasodilatation effect will be there. And if particularly the elderly patient or a diabetic or an infant or a child, if we are not taking care of giving a fluids, either in the by keeping them starving for a long time, overnight starving, or we have not bothered to give some fluids in the cath lab itself, there can be. And elderly people, I have made out if you are making them to lie down for a long, they complain of back pain, and sometimes there may be little bit of a neuritic lingering pain because we have hit the nerve radical before I puncture into the femoral artery. And these are some of the issues which we have faced in coronary angiogram. These are the common complications. And the amount of the dye we have used, if you have combined the right heart study, left heart study, coronary angiogram, and a large amount of the dye, there can be even renal dysfunction also, renal failure. This is a dreaded complication we see often while doing a PCI procedure rather than with the coronary angiogram. I have seen patients, diabetic patients, uh, developing, they have taken metformin. That is the reason why I tell my patients to stop the metformin before coronary angiogram. Metformin, sometimes if there is an associated amount of dehydration, fluid deficit, patients can have lactic acidosis. Lactic acidosis, anecdotal reports are there. It has killed the patients also. So, particularly diabetic, you should see, preferably stop metformin. Nowadays, in the PCI procedure, we do left and right, try to concentrate on fluids and the like. But this is one of the important complications in diabetes. I hope, apart from that, during catheterization, there may be a small amount of clot going to the brain. TAS may be there, CVS can be there. So, some of these things can happen. I think I have answered almost all the complications that can happen.
Thank you so much. So thank you for answering that question and making our viewers understand it, about it better. Thank you so much for that. And at the outset, I would like to thank all of our viewers for their ardent participation that they have shown by staying tuned with us and putting across such interesting questions to us. So thank you to all of them. And with this, I would like to thank you, sir, and would like to conclude the session here.
Thank you very much. I hope I have made you knowledgeable in this process. Thank you very much.
Thank you so much, sir. Thank you.
Okay, bye.
With this, we are
Bye.
concluding the session here for today.
Thank you very much. Thank you, particularly having